Okay, so we will share my screen. Here we go. Okay, so thank you, Mandel. Okay, so what we're doing this week is the antiglobulin test, and this is a really, really important test that you do need to know about. And there are exam questions in the mid-semester test and in the final exam on the antiglobulin test. So that's how important it is. You'll be using it every week from now on in your practical sessions as well. Okay, so we're going to go right back to the beginning and start with some basic principles of antibody-mediated red cell destruction, and then put it into context as to why we do the AHG test. It's really important that you understand the principle of the anti-human globulin test. So the principle is how the test works and why we're using it. Okay, so there's a big difference between the principle of the test, the method or the procedure, and the application. Okay, so the principle is how and why the test works, what it is that you're trying to detect. The procedure is your method, and then the application is why we use it and knowing in which circumstances in which we use it. And you can see there that you also need to know the methods and the application of both the IAT, which is the indirect antiglobulin test, and the DAT, which you should already have imprinted on your brain as the direct antiglobulin test. It's really important that you understand the factors that affect the antiglobulin test, because then you understand why you're doing what you're doing when you are carrying out this test, and you are aware of what you need to be careful of. Okay, and the steps really are, well, all of the steps are important actually, but that will become obvious when we have a look at those factors later in the lecture. We also use a variety of different reagents when we're doing the antiglobulin test, particularly when we're doing the DAT, and we talked about that a little bit in Haematology 2. So when we're trying to work out whether it is IgG based or IgM based, and so we use different reagents to tell us that. And of course, you should already understand some of the laboratory significance of the DAT, but we will expand on that as well. So a lot of what you're learning today will be revision from what you learned in Haematology 2, and also for those of you who did immunology. So starting with a review from Hem 2, of course we know that there are three main classifications of anemia, and when we have a look at normocytic, normochromic anemia here, we can see that part of the subclassification is whether or not it's a survival defect, and under survival defect we see hemolysis. And so this is where our immune hemolytic anemia comes in. Remember, we've got quite a large subgroup of hemolytic anemias, don't we? And our immune hemolytic anemia fits in there. As we can see here, so intrinsic or intracellular, extrinsic or extracellular hemolytic anemias. So it's quite a large subgroup, and the part that we're focusing on for transfusion science is the immune hemolytic anemias. Okay, so you can see here we have drug-induced, we have alloimmune, and we have autoimmune. So we've learned a little bit about these in Hem 2. We particularly looked at the autoimmune hemolytic anemias, and we looked a little bit at drug-induced. When we're looking in transfusion, I guess it's still all three that we need to consider, but particularly for today, we're looking more at the alloimmune and the autoimmune. But of course, there's a whole lecture on immune hemolytic anemias later on in the semester. So we know hemolytic anemia, shortened red cell survival, and immune hemolytic anemia is some sort of an antibody-mediated process. So in autoimmune hemolytic anemias, the DAT, the direct antiglobulin test, is usually strongly positive, as we can see for either IgG, IgM, and for complement. We can see that alloimmune, we can also have a positive DAT, and also a drug-induced. We can have whether or not the DAT is positive is variable. It very much depends on the mechanism of drug-induced hemolytic anemia. So there's quite a bit here that we're bringing forward again from haematology too, that it would be very useful for you to go back and to revise. But I'd like to go back to the beginning and actually review the fundamental concepts of antibody-mediated or immune red cell destruction. So how do antibodies cause this? They don't do it directly, they do it indirectly through whether or not they can activate complement. So the DAT is positive when there are IgG antibodies on the red cells. We don't tend to get IgM antibodies hanging around on red cells in vivo, Jordan. So the IgM tends to be able to activate complement and cause the lysis of the red cells in vivo. So that's where we get our intravascular lysis. But there is a component of complement called C3d that is left on the cells after there's been some sort of an IgM interaction. And so when we go through explaining this, you'll see where that fits in. But great question, thank you. You're actually jumping a little bit ahead. But that's fine. That's where we're getting to. Okay, so we know that, as I said, that antibodies don't actually directly lyse cells. They do it by either sensitizing the cells or opsonizing the cells so that they can be removed by the cell-mediated cytotoxicity. So through our macrophages in our spleen, in our liver, in our bone marrow. And they can also do it through complement. So in this little image, we've got cell-mediated lysis. So here is our red cell here, and here is our IgG on the red cell. And so that IgG, it's the variable portions that are able to, the FAB region that actually interacts with the antigen on the red cell membrane, and the FC portion, or the consistent portion, if you like, which sort of sticks out into the extracellular space. And it's actually this FC portion which binds to the receptors on the macrophages, and it's that FC portion that allows the phagocytosis of those red cells. So that's how the cell-mediated lysis works. And so this is typical of extravascular hemolysis, particularly in the spleen. When we're looking at complement-mediated lysis, and calm down, I don't expect you to be able to memorise or to regurgitate the complement pathway, just to have a bit more of an understanding about, first of all, how complex it is and how it interacts with our antibodies to actually cause cell lysis. So there are two pathways, of course, because one would just not be enough. So we have a classic pathway and an alternative pathway. So the IgG and IgM antibodies actually activate the classic pathway. And so you can see here, IgM and IgG feeding into the pathway here, into the activation of C1. And C1 is what triggers the classic pathway. And depending on the class of antibody, IgM antibodies are able to activate complement all the way through to the membrane complex. And it's this membrane attack complex on the surface of cells that is able to cause, that ruptures the cell membrane and causes cell lysis. Okay, so it's the activation of complement that causes cell lysis. Antibody is able to activate complement. IgG is, most classes of IgG are not able to fully activate complement. Some classes are, and you will learn that when we go through the different antibody groups, the different blood groups in next week. We look at those, the additional clinically significant blood groups, and so the majority of those are IgG, and some of them are able to completely activate complement, but most are only able to get to this stage here, the C3b stage. And so this is where we get opsonization of our cells here. So here's our B cells secreting IgG. The IgG attaches to the cell membrane, is able to fix complement to C3b, and so that's what we call opsonization, or coating the cells, making them more receptive to interaction with macrophages and extravascular phagocytosis. Our IgM antibodies here are able to fully agglutinate our cells in vitro, and so we can see that in vivo they're able to fix complement to the membrane attack complex stage, causing intravascular red cell lysis. Okay, so they are the two ways in which the complement system works and interacts with our IgG antibodies and our IgM antibodies. So IgG, able to sensitize the red cells for extravascular hemolysis. IgM is able to activate complement all the way to the membrane complex and thereby cause intravascular hemolysis. Okay, is everybody happy with that? Any questions? Okay, so the other thing I wanted you to notice here on this slide here is this little baby here, C3d. So C3d is a breakdown product of C3b. Okay, and C3d has the ability to hang around on red cell membranes long after many of the other complement factors, complement proteins, whatever you want to call them, have been degraded. So that's just something to hold in your brain for a little bit later in the lecture, that when complement is activated, particularly when it's activated by IgM antibodies, that we get some C3d hanging around on the red cell membrane. Okay. So a bit more terminology. I think this is terminology that you're quite that you have heard before. I think we talked about this in HEM 2, about the fact that IgG are perhaps known as incomplete or non-agglutinating antibodies, whereas IgM are known as complete and agglutinating antibodies. And this is to do with their ability to directly or agglutinate red cells or not, basically, because still the hallmark of transfusion is being able to visualize that agglutination. Okay, so we still rely very much on that ability of an antibody to be able to agglutinate red cells. IgM can do it directly, IgG need help. So this table here is from Harmoning, and it shows the blood group antibodies that are known to be capable of binding complement and thus leading to red cell hemolysis. And we will be learning about some of these next week. So we'll be learning about Lewis, KID, the I system and the P system, and also some of our RH system here, the Kell system and the Duffy system, and S down here as well. So some of them are capable of binding complement, for some it's rare. Now these rare ones are all IgG. The majority of the most column are IgM, except for the KID antibodies here. they're IgG class 3. And so IgG class 3 are able to bind complement and fix complement to the membrane attack stage. All right, so why can't IgG directly agglutinate red cells, whereas IgM can? And it's all to do with size. And it's to do with this thing called the zeta potential. Now, we all know that red cells are naturally repelled from each other because they have a number of negatively charged residues that stick out from the surface of their membrane. So they're sialic acid residues, and so that gives them a net electronegative charge on their cell surface. And so this charge is then in an electrolytic solution, which of course our plasma is able to then produce this positively charged ionic cloud around them, okay, because negative charges attract positive charges. And it's actually this ionic cloud that's around them that stops the red cells from clumping together, and so it helps them to flow smooth through our microvasculature. You can see here that the ionic cloud, the zeta potential, keeps the red cells 25 nanometers apart. The size of an IgM pentamer is 35 nanometers. So the IgM pentamer is able to bridge that gap. The size of an IgG monomer is only 14 nanometers between its little Fab arms. So it is too small to bridge that gap. And so that is why IgG antibodies in the main are not able to directly agglutinate red cells. They can only sensitize them. They bind to the antigens on the cell surface, and that's where they stay. Whereas IgM is able to agglutinate the red cells because it is able to bridge the gap between them. And so that can agglutinate them. So this zeta potential is really important because it's a zeta potential that if we are going to detect the presence of IgG antibodies on the red cell surface, it is the zeta potential that we need to overcome. And there are a number of different ways in which we can do that. And one of the ways in which we can do that is the antiglobulin test. Okay, so the antiglobulin test allows detection of the IgG antibodies using an agglutination technique that overcomes the zeta potential. So it's really important that you understand what this zeta potential is. So it's the difference in charge density between the inner layer of the ionic cloud, which is just on the red cell surface here, and the outer layer of the ionic cloud. So it's the difference in charge density between here and here. And it's enough to keep the cells 25 nanometers apart. And it only happens in an electrolyte solution, of course, because that's in non-electrolyte solutions, you're going to get those charged particles. And I'm sure that most of you know that the way in which the antiglobulin test overcomes the zeta potential is by actually bridging that gap. But again, I'm getting a bit ahead of myself, so we need to learn a little bit about the history behind the antiglobulin test. So the principle of the test and how it works has been around for about 100 years, but developing an application for the test has only been around for about 40 years. So this is often what happens in I don't know, in research and with inventions and inventors, is that something will be discovered, you know, a process or a principle about something will be discovered, but nobody will, then the idea is, okay, well, good, we've got the discovery, but what use is it? And so it took nearly 40 years, or nearly 40 years to actually devise a use for this actual test. And so it was Robert Coombs who devised the laboratory use of the anti-human globulin test as a bridging reagent, a way of linking IgG antibodies bound to the surface of adjacent red cells and causing agglutination of those, what he termed the sensitized red cells. And so this is why we call it the Coombs test, because of Robert Coombs. And you can see here that it was used for the detection of weak or non-agglutinating rhesus or IgG antibodies initially. So rhesus is what was the name of the Rh blood group. We don't call it the rhesus blood group anymore because that's been shown to be a little bit different, but it's the Rh blood group that we call it. And so they at the time were the most clinically significant antibodies that they had trouble detecting, and that is because of hemolytic disease of the fetus and newborn. And as you can see there, used for in vivo sensitization or detection of those red cells in babies with hemolytic disease of the fetus newborn. And so when we have a look at this, this image again from week 1, you can see in 1945, before 1945, we had discovered 1, 2, 3, 4, 5 clinically significant blood groups. After 1945, once we had applied and found an application for the indirect antiglobulin test or for the antiglobulin test, there was this explosion of blood groups that were discovered because the majority of these blood groups, the antibodies are IgG. And so we hadn't had the tools to be able to detect these antibodies before. We knew the antigens were there, but we couldn't detect the antibodies because we didn't have the method of doing so. So it's a really, really important test, and it's still the basis of everything that we do in transfusion when we're looking at providing compatible blood for patients. So I've just noticed that we've gone about 20 minutes, so I'll just have a bit of a break here just for a couple of minutes, just for you to just sit and have a bit of a think, particularly around the zeta potential and particularly around about how complement interacts with IgG and IgM. Okay, so just a couple of minutes and then we'll continue. Okay. I guess what I should have asked before we start was, does anyone have any questions? So remember, yep. Sure. I'm not sure quite why what you mean, Bassem, when you say the negative charge on the surface repels the positive charge of the vessel. Is that the blood vessel that you're talking about? Yeah, so the negative charge on the red cell surface, what it does is it actually attracts, I'll go back to the slide. Whoops, where am I? Oh, come on, arrow. Here we go. Okay, so here's our red cell here. Yep. So on the surface of our red cell, we have a number of negatively charged, what we call negatively charged proteins that have got a lot of sialic acid residues in them, and it's the sialic acid residues that give the negative charge to the surface of the red cell. When you put red cells in an electrolytic solution, so that's a solution that is able to, it's a polar solution that is able to break apart compounds into their positive ions and their negative ions, then what happens is that because the negatively charged red cell surface attracts the positive ions within that solution. Okay, so they don't bind, they're just attracted there due to the difference in electronegativity. Okay, so the charge density is different. Okay, so we've got an electrical potential because we've got negative surface, red cell surface with the sialic acid charges. Then we have the attraction of all of these positively charged ions within the solution, and that gives us sort of like a, well, it's called a cloud. Okay, so it gives a little bit of a buffer. Again, it's a little bit like some bubble wrap around the red cells. So they stop the red cells from getting too close to each other. They stop the red cells from banging into each other, and they allow the red cells to flow smoothly through blood vessels. Yeah. So when we talk about the zeta potential, it is the difference in the electrical potential between, or the difference in charge density between the surface of the red cell and the external surface of the ionic cloud. Okay. So this bit's going to be sort of most positive because these ones in here are sort of cancelled out a bit by the electronegativity. So it's most negative just at the surface of the red cell, and it's most positive on the external layer of the ionic cloud. And that zeta potential, so that gap there, if you don't actually see it in the drawing here, but just imagine there's lots of little pluses all through here. Okay, and it's the little pluses that have been attracted to the minuses from the red cell, which keep the cells 25 nanometers apart. Okay, so the zeta potential is that 25 nanometer gap. Okay, and whenever, if we want to get red cells to agglutinate, we need to overcome that zeta potential. And there are a number of ways that we can do that in vitro, but in vivo, the only way that it's done is IgM antibodies. Okay, so they are just naturally able to bridge that gap because they are 35 nanometers in diameter and that gap is 25 nanometers. Okay, so one of the ways in which we can bridge that zeta potential is by using the antiglobulin test. And that then allows us, the antiglobulin test then allows us to detect whether or not we've got IgG on the surface of our red cells. Okay, is everyone happy with that? Any questions about the zeta potential? Right, okay. Rightio. So now, so how does it do this? Okay, so the anti-human globulin test or the indirect antiglobulin test and the direct antiglobulin test use anti-human globulin. So as the name suggests, it is an antibody to human globulin. And so it needs to be raised somewhere other than humans. Okay, so we usually use another mammal, and in the past, rabbits, goats, and sheep have been used. These days, it's usually rabbits and mice that are used. So what happens is a purified product of human globulin is injected into non-human mammals. Their immune systems respond by forming anti-human globulin antibodies. The blood is then collected from these animals and processed and purified to produce just the globulin, to remove just the globulin. So if you remember from those of you who've done Clin Chem, you know that our plasma contains lots of different proteins, and the gamma globulins are one of those proteins. So that's what we're purifying here. So the antibody class that's injected into the animals is IgG, so that the AHG reagent is specific for IgG. We can also inject animals with C3d. Remember I said that complement fraction, and we will get an anti-C3d reagent, but more of that to come. So you can see here that we usually use the anti-human globulin test to help us to agglutinate our sensitized red cells. So that's red cells that have got IgG on them. And you can see here that it's also used to neutralize serum. Now, I must admit, I've never used this reagent for that purpose. So it may be that there's some other industries or specialties where they do that, but I've only ever used the anti-human globulin in the Coombs test. So just as a reminder of the Coombs test, this is how the antiglobulin test works and how the anti-human globulin actually bridges the zeta potential. So here we have our sensitized red cell. So this is the principle of the Coombs test, okay, or the antiglobulin test. So we have our sensitized red cells with our IgG component on them. We have washed those red cells to remove any unbound antibody and any plasma that might neutralize anything or might stop the reaction from working. And so because the IgG is too small to bridge the, to cross the zeta potential, to bridge the zeta potential and to agglutinate the red cells, we add our anti-human globulin to it. And so that's our Coombs reagent. And so then what happens is that the anti-human globulin attaches to the Fc portion of the IgG antibodies and is able to cross-link the red cells. And we therefore end up with agglutination that we can visualize. All right, so that is the principle of the test. We are adding anti-human globulin reagent to previously sensitized red cells. The anti-human globulin reagent is able to cross-link those red cells and to overcome the zeta potential, and then it agglutinates the red cells that we can visualize. And you will be visualizing it in glass tubes. Okay, everyone happy with that? The direct antiglobulin test and the indirect antiglobulin test are quite straightforward methods that are easy to perform. But it's amazing how often people get confused with why they are doing what they're doing and when to use the test. It's also crucial to get the correct technique so you get the correct results. And so this is why we'll go through this in a very stepwise manner, and you will be dreaming about the direct antiglobulin test and the indirect antiglobulin test. First of all, we'll start with the DAT, and that's one that you should be very familiar with. Okay, so the first thing we need to do is to wash our patient's cells, again, as I said before, to remove any free antibody that might be there. So all we've got left is our red cells that have got antibody attached to them. Okay, so our cells here. And it's called the direct antiglobulin test because we use red cells direct from the patient. Okay, so the direct antiglobulin test is testing the patient's red cells for the presence of antibody, IgG antibody. So then we add our anti-human globulin reagent. Then we centrifuge to help to assist with the overcoming the zeta potential and getting the cells closer to each other so that they're more easy to cross-link by the anti-human globulin. And then we look for agglutination. Okay, very easy, very straightforward test. In fact, when you do the direct antiglobulin test yourselves, you won't even have to wash the cells because Melina will have washed and prepared the cells for you earlier in a 3 to 5% suspension. So you don't even need to wash the cells. That's how easy this test is. Direct antiglobulin test. Everybody happy with that? We are testing the red cells direct from the patient. The indirect antiglobulin test is exactly the same steps at the end here, but we've got a couple of additional steps before we get to washing the cells. Okay, the indirect antiglobulin test, we need to sensitize the cells ourselves. We don't start with sensitized cells. Yeah. The direct antiglobulin test, remember we are testing the patient's cells to see if there is any antibody attached to the cells. In the indirect antiglobulin test, what we're doing is we're testing the patient plasma. I know it says serum there, but we tend to use plasma more these days. We are actually testing the patient's plasma and seeing if there are any unexpected antibodies in the patient plasma. Okay, direct antiglobulin test, we're testing the patient's cells to see if there is any IgG antibody on the cells. Indirect antiglobulin test, we're testing the patient's plasma. And we're detecting it indirectly because in the middle of checking it, we're seeing if we can attach any unexpected antibody that is in their plasma to our screening cells or to our donor cells, our blood donor cells. All right. So we talked a little bit about screening cells last week in the prac, and we'll talk more about them in the tute, and you'll be using them in the prac this week. So screening cells and panel cells, for that matter, are reagent red cells that have been thoroughly tested, and we know exactly what blood group antigens are present on their surface. So these blood group antigens are the blood group antigens of all of the clinically significant blood groups that, again, you will be learning more about next week. So we know the antigens that are present on these cells, in the screening cells and in the panel cells. The difference between them is screening cells, there are 3 cells, and we use those 3 cells, and they've got different mixes of antigens on their surface, and so they help us to see if we've got an unexpected antibody in the plasma in the first place. And then the panel cells, we use an 11-cell panel, and that helps with the identification of the antibody. So the screening cells help to detect whether we've got an antibody there in the patient's plasma in the first place, and the panel cells help us to identify that antibody. Okay. So then we have to incubate the cells, and so that allows time for any unexpected antibody in the patient's plasma to attach to the screening cells or the panel cells, or in fact the donor cells. Okay, so that allows, so this sensitizing phase. So the direct antiglobulin test, we don't need a sensitizing phase because the cells have already been sensitized in vivo. The indirect antiglobulin test requires a sensitizing phase. That's the big difference between them. Okay, once we have sensitized the cells, if there is a antibody there to detect, we then go through and do exactly the same as we did with the direct antiglobulin test. We wash the cells to remove any of the excess plasma and any excess unbound antibody that might be there. We then add our AHG, we centrifuge and we read. Hang on, I've just got to get my arrow working. Oh goodness, where have you gone? So Kiani, you depending on what other reagents you add to it, you can incubate it for 30 minutes, but these days we incubate it for 10 minutes. And we'll talk about that more in the tutorial. Okay, but if you have a look in, no, not for long at all. If you have a look in your method book, then it gives you an idea about the full method. But at the moment, what we're interested in here is the the abridged method. Okay. Okay, so we had a look at the indirect antiglobulin test in image form, so let's have a look at this one. So again, we've got our sensitized red cells. Just ignore that arrow for the moment. Again, we need to add our anti-human globulin reagent. Again, that cross-links our red cells. So the big difference, so this bit's the same. This is the final bit. This is the same as the direct antiglobulin test. The bit that's different is this first bit. We use reagent red blood cells. So these are cells that we know the blood group antigens that are on their surface, and we add them to the patient plasma. And we're looking for any unexpected antibody that might be in the patient plasma. Okay, so that's the bit that's different between the two. When I say unexpected antibody, what am I talking about? What's the difference between an unexpected antibody and an expected antibody? Can anybody think of an example of an expected antibody? Beautiful. Anti-B in group A blood. That is an expected antibody. Because we know with our ABO blood group system, we have antibodies in our plasma to the antigens that we don't possess on our red cells. So we would expect a group A person to have anti-B antibody in their plasma. Okay. What we wouldn't expect is a group A RHD negative person to have an anti-D in their plasma. That is an unexpected antibody. Okay. So an unexpected antibody is an antibody that needs to have been, if you like, it's an immune antibody. It's an antibody that needs to have been produced as a consequence of a sensitizing event. Okay, so in the case of anti-D, it could be that the person had been given blood, RHD positive blood, or it could be that a mother has given birth to an RHD positive baby. Okay, so some sort of a sensitizing event, but these are our unexpected antibodies. They're not there normally. Does that make sense to everybody? Great. I'm not hearing any donks or hands up, so that's excellent. Okay, so now I'm going to put up a video that will hopefully help you to understand a little bit what's going on here. So I've just got to try and stop sharing this screen and see if I can share the other screen. So just bear with me here. Share screen. I've had to. I've just been to the lymphedema clinic, and I have to wear a lymphedema sleeve and glove, and the glove's a little bit hard to do. Okay, if I share that, I'm just thinking this might go wrong. Can you see the YouTube video? I don't think you can. Oh, you can?
Yep.
Brilliant. So just let me know if you can hear this or not.
Can you make the screen bigger?
Sure.
Yeah, can anyone else?
Jen, I can't seem to hear the sound very well.
I'll let it run to see if we can record it. Whoops. Okay. I don't know if that worked or not, but what I'll do is I'll put that URL on the week 3 discussion board, and then you can go and have a look at that yourselves. I think that's a really, really nice short explanation of the two tests. Was anyone able to hear that, or did you have trouble with the audio? I think a few people couldn't hear it, but at least you could follow the images anyway. Audio was pretty soft, yeah. Okay. Yeah, anyway, so as I said, I'll put that URL up on the week 3 discussion board, and please go back and have another look at it because it really is quite a lovely video. Okay, so we're at our first learning checkpoint. So while you're reading that learning checkpoint, what I'll actually do is I'll put up those alternatives on our little poll that we're used to using. So read that, and I'll put the poll up. Whoops. And I'm showing that to you, aren't I? Oh no, that's fine. So with these learning checkpoints, see if you can do it without looking back in your notes, because it's really trying to check and see how much you have actually taken in through the lecture. Okay, so there are your choices. Okay, come on, 2 people to go. Go, go, go. All right. Okay, so yes, C is the correct answer. So the difference in electrical charge between the red cell surface and the surface of the cationic cloud. That's what the zeta potential is. What it does is it surrounds the cells and keeps them apart. Okay, well done. All right, next one. So red cells must be washed at least 3 times with BNS before adding the Coombs reagent. To have a look at those 4, and again, I'll set the poll up for you. Okay, so red cells, hang on, I'll just move that. I can't. Red cells must be washed at least 3 times with BNS before adding AHG to yes, so it is to remove traces of free plasma protein. Well done. Excellent. Okay, so we have a 10-minute break here. I've noticed it's 12:55, so we'll come back at 1:05 and we will continue on with the lecture then. Has anybody got any questions up until now? Okay, so I'll see you in about 10 minutes time. Okay, so we're back again now. So I'll just share our screen again and we shall continue on. So what I'd like you to do now is actually to break into 3 groups. And so I'll just randomly assign the groups. So please don't move from your groups. But in your 3 groups, I'd like the first group to think about the factors that influence the anti-human globulin test and explain how you think they do so. So just on what you've learned so far about how the indirect and direct anti-globulin tests work, the indirect and direct Coombs tests work, and how and what you know about their methods. So what do you think the factors would be that influence that test? So that's the first group, group 1. Then the sources of error. So group 2 will list some causes of false positive AHG test reactions and see if you can explain how they do so, just on what you've been learning about. And then the final group looking at some causes of false negative AHG test reactions and explain how they do so. So I'll put you into 3 groups.